What is going on, everyone? This is Dr. Josh Funk, and you are listening to the Strength and Knowledge Podcast.
Good morning, everybody. This is Dr. Zach Baker of Rehab to Perform and R2P Academy. And today with us on our podcast, we have Dr. Seth Hawks, one of our two sports residents here at R2P. And this is our monthly journal article review, where our residents, along with the theme of whatever we're learning in the residency, select a journal article, and then we come on here and discuss it. So we are in the month of January. January is the month of the hip for what we are learning within our didactic and classroom portion of the residency. And Seth ended up finding an article that is hip-related, but how that hip impairment can be associated with another lower extremity injury. So, Seth, welcome. And do you mind telling the audience just what the article was that you chose?
Yeah, so the article that I chose is on restrictions in hip internal rotation being associated with an increased risk of ACL injury.
Awesome. ACL injuries are one of my favorite things to work with, partially just because, one, it's a relatively prevalent injury, which I'm not happy for. I don't like the fact that there's a lot of ACL injuries. But with that prevalence and just that high incidence of injuries, you often tend to get a lot of literature and a lot of research around it. So that is always comforting as a clinician because you have things that can help guide decision-making. For patients, you have a lot of data out there that can help frame up expectations. There's a lot that we know about ACL injuries. There's still a lot that we have an idea that there's a relationship or there's a correlation. It's just really hard to figure out, is this causative or how much does it play a role in? And I think this research article, at least from what I've gathered, is a really good representation of that. And I think we have two different variables that often go hand in hand, but hopefully this can help us appreciate some of the factors in regards to how much they go hand in hand. So, Seth, do you mind talking a little bit just about really the background, the objectives? So, why did this study even come about? And then if you could dive into a little bit of what the study actually consisted of.
So through all the data that we've collected throughout the history of ACL research, we know that 80% of ACL tears and injuries are non-contact. They're more of the jump landings, pivots, breakings, change of directions. And we know that those bigger motions like that, they develop a larger tibial rotation torque, especially adding towards that peak ACL strain force. And we know restrictions of internal rotation at the hip could cause there to be a greater requirement of internal rotation of the tibia to complete the tasks of change of directions, jumping, landing. So really this study was looking to see the correlation of ACL injuries with hip range of motion in a consecutive series of elite contact athletes, and then also to test if that restricted hip range of motion in a dynamic simulation model of a pivot landing would increase the resulting peak ACL strain.
Awesome. And I know you just mentioned, up to 80% of ACL injuries are non-contact related. And you'll see that number differ a little bit, but it's safe to say 2/3 or over 2/3, and almost all the literature you see is going to be related to non-contact injuries. And you touched on the fact that a lot of this has to do with multi-directional movement, the ability to move one way, decelerate, change direction, and redistribute force in another manner. The knee is involved in that, but it's not the only piece of the puzzle. We've got the entire lower extremity, and you can even work your way higher up the chain. I've seen different studies and literature that talks about, thoracic mobility and trunk mobility and our how we go about our strategy of positioning our body to change direction. But with the knee, at the knee, we're going to have the femur and we're going to have the tibia. And our ankle and our hip are going to play a large role in how well we manage rotational forces through the knee. And hip internal rotation is going to be extremely important in regards to how well we can control either dynamic valgus or the amount of rotational stress going through the ACL. And if we lack that at the femur, it's safe to say we're probably going to have to excessively rotate through increased tibial torsion and have more tibial torsion demands with that. You had mentioned this is elite contact athletes. Can you talk a little bit about the patient population, who this study was actually utilizing as their sample, And then what did they do for interventions and assessing outcomes?
So this article pretty much was two separate research studies that happened at the same time. So when it comes to the athletes that they worked with, it was all of the participants of the 2012 NFL Combine. So it was 324 football players there for that. They basically took the medical examination that each player has to go through at the Combine and looked at their past medical history, looked at their range of motion, hip, knee, everything like that. And out of the 324 athletes there, 34 of them had a history of an ACL injury that required reconstruction.
Good. So a little over 10% of the participants had history of ACL surgery.
So from there, they took that and just kind of looked at the correlation of what their hip internal rotation was for the ACL reconstruction players, and then also for the players that didn't have any ACL injury history. So for this portion, it showed that there was a correlation, but there wasn't necessarily causation. We don't really know exactly if they had that or not beforehand. But there was a significantly statistical difference for that. But it showed that it was more for if it was the left hip internal rotation restriction versus the right hip for some reason. I think it probably has to do with just which leg is dominant. Typically, most people are more right-sided dominant. So that was the portion of it that went through more of the elite athletic population side. The other portion of the study, they first talked on a study that had happened in the past that they, the researchers before them, they had taken a cadaver leg, placed it in an apparatus that would apply a compressive force, an internal tibial torque, and a knee abduction simultaneously. So through that, they gathered the joint kinematics. They recorded it with a motion capture camera system, and was able to get ACL relative strain recorded using a differential variable reluctance transducer. So from that, they took all of that information, placed it into a simulation software, and recreated it through the software. Once they were able to perfectly validate it through that, they then added in that software a rotational stiffness of the hip joint to simulate that mechanical impingement that would be associated with that restriction. So from there, they saw that for every 1 degree of limitation of internal rotation, there was an extra 0.28% ACL strain increase. So if you're missing a lot of that, if you're only getting to neutral, that 0.28% adds up pretty quickly. So it just kind of leans back into that idea that decreased internal rotations can definitely increase your risk of that ACL strain.
Cool. So the way that I look at this is they tried to find the correlation of hip internal rotation deficits to potential relationship to ACL injuries. One, by looking at 324 2012 NFL Combine athletes, 34 of which, so a little over 10%, had confirmed ACL surgeries in the past. And then they went and they screened all of those individuals, looked at their hip range of motion scores, and there was a higher prevalence of individuals who had poor hip rotation and an ACL surgery than those who did not have poor hip internal rotation and went through ACL surgery. So there's already a relationship found there just with the presence of the people who had ACL surgery in the past also have a higher likelihood of having hip internal rotation. Now, we can do chicken or the egg. Is that hip internal rotation deficit, was that there prior to the ACL surgery and it predisposed them to having an ACL injury? Or from that information, do we take away when you have ACL surgery, you are more likely to have hip internal rotation deficits post-operatively? We don't really know that one just based off the information here, but they were able to find a pretty clear-cut delineation between people who had a history of ACL surgery were also the ones showing up to the combine with hip internal rotation deficit. Then the other way they looked at it was they tried to take that biomechanical model of, all right, if we know what the mechanics of the joint are, how the femur, how the tibia articulate, what the ACL's role is in regards to minimizing anterior tibial translation and rotational components of those two bones interacting on one another. And we know what the normal strain on that ligament is. How does a deficit of hip internal rotation increase the amount of strain that is on the ACL? And they found for every degree that you lack of hip internal rotation, you're going to have an extra 0.28% ACL strain, which, like you mentioned, if you're missing 1 or 2 degrees, probably not a big deal. If you have a 15, 20, 30-degree hip IR deficit, now we're getting into double-digit categories in regards to increased risk, with increased strain on that ACL. So I like the kind of the two different routes that they went with this study. One just more pretty black and white of, hey, if you lack hip IR, you are going to increase strain on the ACL with these common movements that are happening on the field. And then also the real-life example of when we look at people who have ACL injuries, there's also a common lack of hip internal rotation. Now the million-dollar question with all of this, what do we do with this information? And I guess, coming away from this article as a clinician that works regularly with athletes, what do you take away from this article, either in regards to, I don't like saying the word injury prevention, but putting athletes from a training and a performance standpoint in a lower risk profile, or if somebody has ACL surgery, how do you incorporate some of these findings into your rehab postoperatively?
I think a big aspect of this on how to apply it more towards that clinical side is don't neglect the joints above and below. If somebody comes in and they've had some knee stuff going on, don't focus directly on the knee. It's easy to get caught up exactly on what's bothering them and not necessarily looking at what is causing that. Getting more into that, let's look above and below on the chain. Let's figure that out. And, not to forget that mobility does matter. At the end of the day, if you're not moving well, you're not going to be able to perform well. So keeping that mobility type aspect into the treatment, kind of making that kind of muscle memory into the patient of, don't forget, you need to stretch. You need to keep that mobility where you have it. Don't let that get worse when we're done working in physical therapy and you're back to performing. Make sure you keep up with this type stuff.
Yeah, and I think it's something where it provides you opportunities for interventions at various phases of the rehab as well. So when you have an ACL surgery, obviously the big things you want to get back postoperatively, you do want to have tunnel vision on that knee. We want to get rid of symptoms. We want to restore full knee extension and full knee flexion. And we want to normalize just muscle output at the quadriceps and hamstrings. But the quads and hamstrings, they're going to be kind of at the mercy of the positions they are put into function. And if we lack ankle dorsiflexion, we lack hip internal rotation, when we try to do different athletic maneuvers or even things in the gym and in the weight room, if the ankles and the hips can't put the knee in an optimal position to function, it doesn't really matter how strong you are. Or how strong you are, you're not able to exhibit that strength and that ability to your full degree. So at different phases of the rehab, you may be limited with how much you can actually train the knee. Maybe they're not tolerating it well. They have a very high symptom profile. They're very swollen. They're very irritated. And this may provide you opportunities for interventions at adjacent joints when you're relatively limited in that postoperative protocol with what you can do at the knee. Or the other end of the spectrum, they're crushing their rehab, and they're doing really, really well. They don't have a lot of symptoms. They've restored their range of motion at the knee. Their strength is tracking very, very well locally at the knee. Awesome. Let's start seeing what we can do at the adjacent joints, and let's see if we can start programming in some ankle and some hip activities, either from a dynamic stability standpoint, an isolated strength standpoint, or just an integrated functional strength and conditioning as well. And then mobility also. We hammer in knee extension torque and knee extension strength and force output is very, very important following ACL surgery, but so is the ability to get in and out of ideal and optimal positions from a kinematic standpoint. And if we're looking at different change of direction tasks, we're looking at different deceleration tasks, yes, the knee is heavily involved, but so is the hip, so is the ankle, so is the trunk, and things higher up that chain as well. So I think This article, does it answer every question? No. Does it confirm some assumptions that we've probably had? Absolutely. And I think that we can take this article, feel a little bit better about some of the assumptions that we have, and utilize it to help frame up some of the conversations that we have with our patients. Seth, any final words or thoughts on this before we close out?
Really with this is, keep it dynamic when you can, but if you need to focus in on it, focus in on it.
Cool. All right. Well, Seth, as always, thanks for doing the dirty work and going through the research, and look forward to having you on next month.
Thank you.
Thank you for listening to the Strength and Knowledge Podcast. If you enjoyed this episode or have been tuned in for multiple episodes, we would love for you to subscribe, rate, and give us a review on Apple Podcast or Spotify. Until next time, thanks for listening.